Hi everyone, so one of my assessments is the Pediatric Evaluation of Disability Inventory, aka the Pedi. The purpose of this assessment is to measure functional status in self-care, mobility, and social function among children with pediatric disorders between the age of 0 months to 8 years. It is a performance measure that should take between 31 to 60 minutes. However, I did find that some other places said that it takes 40 to 60 minutes, depending. The equipment needed is the score form, a writing utensil, software program, and the manual. And the areas that assesses is EDLs, behavior, cognition, communication, eating, functional mobility, infant and child development, language, life participation, occupational performance, reasoning and problem solving, and social relationships. This assessment falls under the ICF domains of activity, participation, and environment. Training is not needed in order to administer this test. It can be administered by parent, caregiver, structured interview, observation, and/or professional judgment from therapists or teachers, or a combined method. The total number of items is 197. There is also a computer-adapted test, which is a revised version of the Pedi that uses item response theory, which is a paradigm for the analysis that measures abilities, attitudes, or other variables. It's called the Pedi-CAT. This revised version expands their age from birth to 20 years, and there is also a version for use on the autism spectrum. Unfortunately, this assessment is not free, and here's the breakdown. All subcategories, including self-care, mobility, and social function, are all scored by either 0, unable, or 1, capable. Here is Part 1, functional skills, specifically the self-care domain. Part 2, which is caregiver assistance, is scored from 0, being total assistance, to 5, being independent. Part 3 asks about modifications, whether the child needs extensive modifications or no modifications. Here is what Part 2 and 3 look like. This is the score sheet. Unfortunately, I did not have access to the manual, but that is where I assume you can find the normative standard score and standard error, and that's where you can figure out the fit score. Demonstration time! I would suggest you guys look along with the manuals to follow my scores. So as you can see here, I was able to hold my head in position while my hair was being combed. I can bring the brush or comb to my hair. I was able to brush or comb my hair. I was also able to manage tangles and part my hair. In this clip, you're able to see me climb and descend a full flight of stairs, which is 12 to 15 steps. If you go under mobility domain for section 1 and go to tub transfers, you can see that I'm able to step and transfer into and out of an adult-sized tub. Here's the normative data found, separated by age, and then functional skills and caregiver assistance, and between each 3 domains. Here are some more psychometrics. For inter-rater reliability among a normal sample, it was excellent when tested by nurse practitioners and PD research members. Among clinical samples, there was excellent reliability when tested by members of a rehab team and family members. Internal consistency, age, children between 2 to 5, there was adequate to excellent reliability, and children older than 5, there was adequate to poor reliability. And among a normative sample, it was excellent, with Cronbach's alpha range being 0.95 to 0.99. Concurrent validity among CP population was excellent, with the Peabody Developmental Motor Scale. With myelodysplasia or juvenile RA, there was an excellent correlation with the Battelle Developmental Inventory Screening Test. Conversion validity was excellent, and content validity was strong. Unfortunately, I was unable to find the MCID or the MCD, but this may be due to the fact that children are unable to determine whether or not they're developmentally delayed. This research study I found was comparing 3 different intervention approaches which was child-focused intervention, context-focused intervention, and regular care intervention. This study found that there was a significant change in children with CP in regards to self-care and mobility within a 6-month time span. What does this mean? Although this does not tell us much about the assessment itself, I did, however, find research that was studying the effects of therapy in self-care, mobility, and social function domains that use the PD as the outcome measure. In my opinion, it seems that the PD is a good outcome measure used to measure functional changes over a time span. Here are some biases and things to consider. 1. I thought it was slightly lengthy. Although it says it takes 30 to 60 minutes, it seems like it might take a little bit longer depending on how attentive your child is and the child's function level. I also thought that home environment may inhibit the completion of some activities. So for example, for stairs, it said climb and descend a full flight of stairs, which is 12 to 15 steps. Some families may not be able to complete this task due to living in a one-story house. When you're observing a client, make sure you're thinking about caregiver assistance and modifications while you're doing part 1, because you don't want to go back and do the task 2 times. My other assessment is the Earhart Developmental Prehension Assessment. The EDPA measures functional age of the hand, testing involuntary arm-hand patterns, which are reflexes, voluntary movements, and pre-writing skills. The age range for this test for part 1 and 2 is 0 to 15 months, and part 3 is 1 to 6 years. Population includes developmental disabilities, early intervention, hand evaluation, pediatrics, and special education. It is a performance measure and observation measure that takes 1 to 3 hours, or in the short form, 30 to 60 minutes. The ICF domains are body function and activity. Equipment includes a graded series of 3 dowel shapes, approximately 1 cm to 2.5 cm diameter, a graded series of 3 cube shapes, approximately 3 cm to 6 cm wide, graded series of 3 edible pellets, approximately 5 mm to 1.5 cm in diameter, graded series of 3 large containers, nesting boxes, approximately 5 cm to 8 cm wide, graded series of 3 small containers, pill bottles, approximately 1 cm to 3 cm diameter, a pencil, which is 7 mm in diameter, and a crayon, which is 1.5 cm in diameter, segments of black and white yarn and thread, and a test kit container, which is a plastic bucket or a tote bag. Here is the breakdown of the assessment. Part 1 is the formal test, which includes 3 sections. Section 1, primary involuntary arm-hand patterns. Section 2, primary voluntary movements. Section 3, pre-writing skills. And Part 2, which is scoring the developmental level of the child. And Part 3, which is the score sheet summary. On the protocol sheets, there are large boxes and small boxes. The shaded large boxes are the norms. You can give people a plus, which all patterns components were present, a minus, no pattern components were present, a plus minus, some but not all pattern components were present, and a plus plus where all pattern components were replaced. On the protocol sheets, there are also small boxes on the right. The shaded boxes are the norms. This pattern will continue through life. The unshaded boxes, this pattern will not continue through life. A plus means that it's well integrated and it's a normal pattern. A minus means that the pattern was not present. A plus minus means it's emerging or abnormal pattern was not well integrated. A plus plus is transitional pattern was replaced by more mature patterns, and a 0 is intervention needed. For scoring Part 2 and 3. Part 2, you're just going to transfer the scores from the protocol sheets onto the score sheet. For Part 3, you're going to estimate the child's range of developmental levels and record it on the score sheet summary. Here are the reflexes that are included in Section 1 of Part 1. Ken and I will be testing Part 1, primarily involuntary arm-hand patterns, specifically the ATNR. His ATNR is fully integrated. Here is a list of the voluntary movements that are tested. This is section 2G, manipulation skills. Here is what Part 3 tests. Here we are working on Section 3, pre-writing skills, drawings. Here is what the developmental level score sheet looks like. The patterns, movements, and skills seen in the demonstrations were considered normal. Here's what Part 3, this score sheet summary, looks like. Due to the lack of research out there, I was unable to find good psychometrics. There were no norms that were found. In a thesis that was written, intra-class correlation coefficients range from 0.78 to 0.88, which is considered acceptable. There was high inter-observer reliability. In the thesis, the results showed that the revised version of the EDPA was highly reliable when used by different observers. The two observers who participated in the study had very different levels of clinical experience, one with 2 months and the other that had 9 years of pediatric experience. And for validity, the correlation between scores of the EDPA and the PDMS was 0.85. Here are some of the biases. I figured that more research should be conducted using this assessment because there was a lack of research out there that I could find information on. There was also a lack of solid psychometric data, so another reason why there should be more research. I believe that the instructions should be more clear as they seemed a little bit confusing, as well as scoring seemed a little bit confusing. And there were different languages that include English, Spanish, and Japanese. Thanks for watching, everybody!